literally slow movement. But I think what's not appreciated well enough is it's not merely slowness of movement, but it's actually a diminution, increasing decline in the amplitude of a movement. And I'll give you some examples of this. Hopefully my videos will show, and I'll show you what I'm talking about. But I think also what's not appreciated is that it's also a decrease in what we call automatic movements. Automatic movements, as the name implies, are movements that we make in a basically unconscious manner. They include when we're walking, swinging our arms. As we take a step, the opposite arm comes forward. Now, a person with Parkinson's who's told, why aren't you, you're not swinging your arms, they can make themselves swing their arms for a time. But when you take your mind off it and you're thinking about something else, then that automatic movement decreases. Another example is our facial expression. As we interact with our environment, our facial expression will change. And again, this is most of the time done in a unconscious way. This is why patients with Parkinsonism are perceived as having a stare or a blank look, or, oh, you're depressed. Why are you not more excited about what's going on? This is a form of bradykinesia. Another example is that patients with Parkinsonism drool. They drool not because they're producing more saliva, but because, every minute perhaps we swallow half a dozen times. We're producing saliva constantly, and yet we automatically swallow. Now you can say, well, I need to swallow, but as time goes on, it happens automatically, or it should. In Parkinsonian patients, this decreases, and so the saliva builds up and drooling happens. All of those things that I've just been discussing are forms of bradykinesia. Rigidity is experienced typically by patients as a feeling of muscle tightness, muscle pain, and the clinician can elicit it by checking a patient's passive range of motion of different body parts. The fourth cardinal feature is postural instability, particularly or specifically an impairment of the righting reflex, and I'll show you an example of that momentarily. Okay, so as you see this young doctor walking, as he's going, he takes a step, the opposite arm comes forward. You also will notice that each step he takes, his heel hits the ground first. Okay, in patients with bradykinesia, the arm swing diminishes. The person also loses their heel strike. So that's why it looks like the person is shuffling, because and you also will notice when he makes the turns there, he makes a nice pivot instead of having to take several steps to turn. Now I'm going to demonstrate the righting reflex here. Again, the righting reflex is a brainstem reflex that allows us to recover when our center of gravity shifts from being sort of in the midline to going backwards a little bit. And again, this is impaired in Parkinsonism to various degrees and leads to falling. Normally, here's what it should look like. There we go. So, and I'm also showing his tone there. As I put his shoulders through range of motion, there's no resistance to it, no rigidity of his axial segments or of his neck there. That nice range of motion, there's no resistance to it, no rigidity. And now as I pull, watch how, as he loses his balance, you see how he moved his foot there and stepped. That's a normal righting reflex. So normally we should be able to engage that reflex within 2 steps, maybe 3 at the very most. If it takes more than 3 steps to recover, it's abnormal. Hopefully the next bit of video will be of a patient with Parkinsonism. So hopefully this will show it. This is going to be a patient with a form of Parkinsonism called multiple systems atrophy, or MSA. If it doesn't show, I may have to imitate what these various forms of bradykinesia look like, but hopefully that won't be necessary. Oh, here we go. Good. Yeah. So if you're looking at this patient's face, You can see that he's not blinking very much. He sort of has a decrease in what we call facial hypomimia. I apologize. The segment comes from a teaching video put out by the American Academy of Neurology a few years ago. I apologize that it goes on for a little bit here before it really shows what I want you to see. You're going to see momentarily the patient being asked to do voluntary movements, including things like that we do at the bedside, like finger tapping. What you'll notice is that, again, the amplitude of the movement decreases. That's a hallmark of bradykinesia. It's why patients with Parkinsonism, their handwriting gets smaller and trails off. It's why their voice gets softer and trails off. Those are all forms of bradykinesia. You'll see a pretty good example of it momentarily. Then after he's doing the voluntary, what we call rapid alternating movements, you're going to see his gait. You're going to see that he doesn't swing his arms normally. You're going to see that his heel strike is lost, that his stride is diminished. You're going to see that he takes several steps to turn, and you're going to see that his postural reflexes on pull testing are abnormal, that it takes him multiple steps to recover, and indeed that he is not totally able to recover and would have fallen if the physician had not stopped him. So again, you'll be seeing that hopefully just in the next few seconds. So if you look at the hand opening there, you'll see that you see that how it decreases. The hand's kind of opening and then it diminishes. It's not severe, but clearly there. You see it better with the finger tapping here. That the movements are slow, but not just slow. The amplitude diminishes. Slow movement in and of itself isn't bradykinesia. It's a decrease in the amplitude of the movement. And here with his foot, he's having difficulty doing the foot tapping, that it sort of trails off there. So again, bradykinesia, that I just, in my experience, again, watch here, he's not swinging his arms normally. Also, his heel strike is gone. See there how he turns? He's slow. He takes multiple steps. All of those things that you're seeing are, by definition, bradykinesia. Here's his pull test. You'll see that he takes, you see that, 4, 5, 6, and he would fall. His writing reflex is impaired. That's, again, the fourth cardinal feature of Parkinsonism. It's why patients with Parkinsonism fall. If that reflex is impaired when a person is making a turn, often if we make a turn, this is another lady also, very decreased stride with MSA as well. But I think y'all get the point there, so I'll move on. Okay. So again, the impaired writing reflex is why, for the most part, or a big reason why patients with Parkinsonism fall. Now, as I said earlier, I alluded to, neuroleptics are dopamine blocking agents. That is, as you recall, I mentioned about the brain, one nerve cell communicating with others. The brain, to do that, these telephones, as I use that analogy, use chemicals and they use electricity. The chemicals that we call neurotransmitters. These are chemical messengers which allow the nerve cells to carry out a function, either to cause more nerve transmission or less. Now, dopamine is one of the main neurotransmitters in various parts of the nervous system and very much involved in normal movement. Again, it's been known by laymen and physicians alike for 45 years, since the first antipsychotics like Thorazine came out, that these medicines are very good for helping with psychosis, like in schizophrenics, but they produce Parkinsonism. The reason for that is that they block dopamine not only in parts of the brain that cause the hallucinations, and I'll get back to that in a minute because that figures into patients with Lewy body disease, but they also block dopamine in the basal ganglia, which again, as I mentioned, is involved with normal movement. What's not as well appreciated, and this again is why I want y'all to have those cards with all of these medicines. I listed the big ones, both trade names and generic, because your primary care physicians and other physicians unfortunately are often not aware that many of the medicines that are used for nausea and vomiting, the antiemetics, are basically, well, no, they are neuroleptics. They block dopamine. So medicines like Reglan or metoclopramide, the generic, prochlorperazine or compazine, promethazine or Phenergan. These medicines, while they're